Well, another episode on medical experts in football. I'd like to welcome you all. I'm Tawa Deshikman, your host.
I didn't know exactly. No one knows how to reconduce that to football and how to become a football doctor or an external assessor as I am normally to football clubs and football players. It's very, very difficult to reach there because nobody knows here how to do it.
Yeah.
And you're just making one step forward, two or three steps backwards, then you're going like this all the time, and it's a little bit crazy.
And that's Dr. Carlos Pedret, a Spanish sports medicine doctor. He works today as an external advisor to multiple professional soccer leagues around the world, from English Premier League, Italian Serie A, Spanish La Liga, the Belgium Pro League, and he dabbles in the other sports such as NBA and tennis. And he actually got to meet my favorite NBA player ever. So stick around to hear how his journey unfolded, a Spaniard who has only taken 6 days off of vacation ever. Okay?
First I'm going to say, hola, es un placer conocerte. How is that?
Está bien. Good.
FYI, I work as a physical therapist and sports journalist, but I am hoping to eventually become fluent in Spanish because I want to eventually have the opportunity to cover leagues such as La Liga and different Spanish leagues. So we're still working on it. Where is your hometown city, and how would you describe that city for someone who has never been there?
It's difficult because I am from Reus, which is a town, a city 100 kilometers south from Barcelona. Okay, I was born there, and it's a quite known city because of the architect Antoni Gaudí, the modernist architect, the builder of the Sagrada Familia in Barcelona. He was born in Reus, and I'm from there, and it's quite a big city, a very important city of the last 100 years, more or less. So it was an economic engine of Catalonia and Spain a long time ago, and now it's a big city with a good history. But unfortunately, or not, I'm not living there, because I work in Barcelona normally, and I live in Vilanova i la Geltrú, next to Sitges, which is a seacoast city, very quiet and very calm, and happy to live there.
What's the city called that you said you live in now?
Vilanova i la Geltrú.
Vilanova, and you said it's by the sea?
Yeah.
So are you near the beach, pretty much?
200 meters by foot from home.
Wow. That's amazing. Yeah, I've heard there are beautiful beaches there. Do Spaniards actually surf? Because I guess I don't picture Spaniards surfing. Do you know how to surf?
No, I tried, but I'm not so good at it.
Yeah. What are you good at? What type of activities are you good at?
I'm not good at anything. I just try to make a lot of things, but I don't think I'm good at anything at all. In terms of sports, I try to do as much as I can. So every kind of sports I try. I love practicing sports, but for time, the most things I can do is some mountain bicycle, and then go to the gym. I try to go to the gym every day, 1 hour, just to make a little bit of cardio training and a little bit of core exercises, core stability, because of my back.
I see. Same, likewise.
Yeah.
Very cool. Well, out of the 3 largest cities, because some people will be tuning in coming from all over the world, and Spain is one place that I would like to visit one day. Of the 3 largest cities, Barcelona, Madrid, and I believe Valencia, what makes these cities different? I'm assuming you've been to all of these cities?
Yeah. I have to say, sorry for my Valencian friends. I don't like Valencia.
You got to explain why, okay?
Yeah, I don't like it because it's a little bit more chaotic than the other ones. Maybe it's the city that I've been the last time. So maybe I don't know quite well Valencia. That's why I don't like it so much. But Madrid is very, very beautiful, very beautiful. And there is a huge offer of nightlife, restaurants, places to take a beer, very lovely places, lovely neighborhoods. And also to work, there are a lot of places to be. But for me, nothing like Barcelona. Probably because it's the city I know the best. That's the reason why I prefer Barcelona. I know a lot of people from all Europe that is going to have holidays in Valencia. And I always tell there that I don't understand why they choose Valencia, but I understand that they feel so comfortable there because the Valencian coast is very beautiful also. Yeah. So there are three very different cities.
Why should someone go to Barcelona? What's special about that place?
For me, everything. It's Barcelona. It's very beautiful. In terms of if you want to have fun, you can do it. If you want culture, you can do it. If you want just to walk around, you can do it. If you want to make some different sports, you can do it. So it's the same. It's more or less the same as Madrid, but with sea.
With sea. I see. Okay. Well, before we get into sports medicine, just a couple more questions. I love food. So I always like to ask, what's one dish that you can't go without?
There are a lot. In Spain, the food in Spain is incredible. For me, what we call here pan tumaca, which is tomato with bread and some ham, typical from Catalonia, for example. For me, it's the best, and it's very simple. Just you get a bread piece, then you spread tomato on it, and then olive oil, and then ham, for example.
Interesting.
That's very good.
It sounds so simple.
So simple.
But that's the one dish I should definitely try if I go there.
Yeah, for sure. Yeah.
Okay. Yeah. Well, I believe August is a time for vacation for Spaniards. Is that the case for you? If so, where are you going to be spending your vacation?
I have never done vacations.
Oh,
never.
Not surprised.
No, never. So the maximum period of holidays in my life has been 6 days in a row.
Wow. And you like it like that?
I used to do that. I've never done 15 days or 20 days of vacation, of holidays. So I don't know if it's good or not. I just carry on.
And I'm assuming that's due to all the work that you have, which we'll get to. Okay. Yeah. Well, let's get right into soccer medicine. This is going to sound like a silly question, given that you were brought up in a country where soccer is so present. But what was your exposure like to football? Did you start playing when you were 12 days old, 2 years old? When did you start?
I think I was born with a football in my face. I played football since I have memory. In fact, the thing is that I didn't like medicine. I just like football. So when I finished the career, the degree of medicine here, I didn't know exactly what to do because there was nothing related to football. So yeah. Wow. So because orthopedic surgeon and traumatology was something that could be related in some way, so I started doing that in the hospital. I never saw a football player there. never saw an injury related to football. So crash cars and all the things you see in the emergency room when you are an orthopedic surgeon, but nothing about football. So I decided to change, but not looking something different in medicine, but I was just looking something to relate my career with my passion, which is football. So I was trying to drive all my life towards the football.
Wow. Okay. Well, initially you weren't interested in medicine. It was really football.
Yeah.
But eventually I'm sure there was something about medicine that really inspired you, because there's no way you could study that many years and not have an interest at all. What was that for you?
As I was a football player, not professional, but as I was a football player, and my career wasn't to be a successful career in football field, I decided that I wanted to fix football players. So the only thing I imagined was medicine.
Yeah.
So I started medicine to try to fix football players.
Okay.
That was it. But as I said, when I finished the degree, I didn't know exactly. No one knows how to reconduce that to football, and how to become a football doctor or an external assessor, as I am normally, to football clubs and football players. It's very, very difficult to reach there because nobody knows here how to do it.
Yeah.
And you're just making one step forward, 2 or 3 steps backwards. Then you're going like this all the time, and it's a little bit crazy.
I was gonna say, did you lose your mind sometimes, just thinking, am I doing the right decision? Or
exactly. Well, in fact, a lot of times I thought, what exactly am I doing? Was not easier to become an orthopedic surgeon in a hospital and stay there for the rest of my life and putting prostheses and all these things, or knee replacement. But I really didn't like that.
Yeah.
So I keep pushing on the direction I was thinking about.
Yeah. When you say you kept pushing in that direction, what did that look like? Was it, because really you said you really don't know like what direction to go. Were you seeking advice from people, or were you kind of reading? What did that look like for you?
The thing is that when you finish the degree in Spain, you have 1 year to prepare an opposition to become a specialist.
Mm-hmm.
Okay. And you decide in your mind which specialty you want to do. Then you prepare the opposition, you make the exam, and there are limited places for a lot of doctors. Okay, a lot of medicine students.
Mm-hmm.
I didn't take that exam at the first time. I studied, but I started to work because I didn't have any specialty that I like it. Okay. So there was no football medicine as a specialty. And at that time, there wasn't also sports medicine specialty in Spain.
Yeah.
Okay. So sports medicine here in Spain, it's a political thing. It's in and out of the book of specialties. So at that time, there was no sports medicine specialty, the same as now. Now we don't have a sports medicine. So I just decided not to pass that exam. I studied for that exam, but I started to work as an orthopedic surgeon in a hospital, in the emergency room. But in parallel, I started to go to non-professional football teams around my city, around Reus, which is the city I was living then, just to see how they train, see their injuries and how they treat their injuries. But the thing is that none of these teams, although one of them was a professional team, haven't a doctor there, nor a physiotherapist.
Yeah.
So they just go with a physical trainer. And the physical trainer was the one in charge to readapt the injuries, but normally without any diagnosis and all these things. So my figure there was quite useful because I was a guy that was working in traumatology and orthopedic in a hospital, and I went there to help with the players that was injured. So I started to do that with some kind of team surrounding my city, and again in parallel, I was writing an Excel sheet about all injuries I was looking and I saw in that teams, and how we manage that injuries, and how which was the return to play for that kind of injuries. Okay, and I presented that in a congress, just data of my own data. So I went to that teams 2 seasons, and I had all of that injuries. The diagnosis was that one, the treatment was that one, and the return to play time of that injuries was that. So we can say that in some clubs here, and there wasn't epidemiological studies, so much of them by that time, except from the UEFA, which was the methodology I used for that teams. Mm-hmm. And he showed the attention that the study I presented in that Congress of one of the Football Club Barcelona doctors. Then he said to me that if I wanted to come to collaborate with them in terms of studies and in terms of young teams and academic teams and all these things. So this is how I started to reconduce towards sports medicine. And after that, they opened a window where the sports medicine specialty was available in Spain. So then I took the exam, I passed the exam, and I started the specialty of sports medicine.
And what was that specialty called? Because I know I saw that you also got a master's in sports traumatology and high performance. Is that different?
Yeah, it's different. The specialty is 4 years, and the master degree is 2 years, and it's different. So different things.
Okay.
The specialty of a sports medicine is the same as a cardiologist, for example.
Okay,
so
gotcha.
If you want to become a cardiologist, you do 4 years in a hospital. If you want to become a sports medicine doctor, you do the specialty of 3-4 years. At that time, were 3, also in a hospital. So,
I see.
And then you can do it in parallel. You can do the master degree in sports traumatology and high performance, which I also do.
Okay. Is it common for doctors to want to go on to do like that master's in traumatology and high performance?
No.
Why do you want to do it?
Because I wanted to deep inside the sports medicine traumatology and the sports medicine injuries, the sports injuries. So I don't like sports cardiology. I don't like sports, any other things. So I just like muscle and tendon.
Yeah.
And I don't want to disperse my mind so much because it's limited,
Absolutely.
So
just laser focused.
Yeah. So I prefer to focus in the things I like and I understood the most and deep inside all that.
Yeah. Well, because you like muscle and tendon, I'm really curious from your background, what's the worst muscle or tendon injury that you've had as a player?
I didn't have no muscle injuries. I had 2 longitudinal splits in my both Achilles tendon at the same time in a veteran football match 3 years ago. So it's a little bit crazy.
Wow, both. Yeah. That's interesting.
Yeah. So both Achilles tendon tears, longitudinal splits, no complete tears.
Yeah.
But at the same time, in the same mechanism, in just one football match. So,
Yeah, that must have been a tough football match, or what?
Yeah.
Well, as you mentioned, you love muscle and tendons, and you spend a great deal of your time focused on that today. Early in your career, what did you find initially most annoying when you were kind of dealing with some of these tendon and muscle injuries?
I think muscle is a very noble structure. It's difficult that the muscle tricks you. So you can understand what's happening in the muscle. You can manage what's going on in the muscle, but we don't understand what's going on with tendon. And not when we speak about tendons, we always think about patellar and Achilles, but we need to understand that most muscles have an intramuscular tendon. And here is where we have the biggest problems. That was very well defined by Pollock and all the BAMEC team with the classification of the BAMEC injuries with their type 3, which is the intramuscular tendon tear. But we still don't understand the whole picture of this.
Yeah.
Okay. So we know that there is an intramuscular tendon tear, but we need to understand in which muscle is this and how we understand and how we treat every individual muscle. So it's not the same, a BAMEC 3C injury affecting the proximal part of the common tendon of the hamstrings than a BAMEC 3C injury affecting the most distal tip of the proximal tendon of the biceps femoris. So it's very different in terms of return to play prognosis and treatment. And in terms of classification, it's the same BAMEC 3C.
Yeah.
We need to go a little bit more deeper than the classifications.
Yeah. And we're going to get further about that later on. But I was curious because, we have these classifications, but oftentimes, sometimes some of these injuries don't actually heal within those certain timeframes, right?
No, because it depends on the player. It depends on the specific position in the field. It depends on the sport. It depends on the muscle affected. We wrote and published a small editorial, a small piece in a sports medicine journal last year, which the name was Muscle Madness. And it was about the difficulty to classify muscle injuries and why we are trying to use just one classification to classify all muscle injuries in all muscle groups. It's a little bit crazy. Imagine that you want to do that with cancer.
Yeah.
Just one classification to classify all types of cancer.
Yeah.
It's impossible because every organ is different.
Yeah.
So it's the same. Every muscle is different. So if we want to use just one classification, we suppose that a rectus femoris and a soleus muscle are the same muscle.
Yeah.
And this is not like this for sure.
Right. Well, let's get right into it, your work, because I'm still trying. As I was reading your bio, and I'll be honest with you, I had to take on my Google Translate to translate everything from Spanish to English. So I may miss some things, but aside from being, a sports medicine doctor, you're a musculoskeletal sonographer, return to play specialist, researcher, all of that. Now, when you were, let's say 20 years old, what did you really envision doing with kind of a medical degree? Did you envision doing all of this, being able to reach so many clubs?
No.
What did you envision? What did you want? Let's say that.
As I said before, I just wanted to work in something related with football.
That's it. So I played football by that time, and I was studying medicine at 20 years old, second in medicine, second year. And I was just going on with the degree of medicine without thinking so much. So I normally have short objectives. I don't look too far. Too far ahead.
So I was in the second year of medicine. My main objective was to reach the third year of medicine.
I need to be like you. I think I'd be less stressed because I'm always like, okay, I got to get this done before 2 months or whatever.
Imagine at 20 years old that my objective was to assess 18 or 19 clubs all around the world as external assessor from players' injuries. That was crazy. I turned crazy if I was thinking like that. So I was in second year of medicine. So my main objective was to reach third year of medicine, and then the fourth, and then the fifth, and then the sixth. So from there, everything is going.
Yeah. Wow. So for you, it's just like that passion was so great that, that literally kept you on focus on what you wanted to do, not so much the end result.
Yeah.
Yeah. Well, what's a day like for you now? Because obviously we'll talk about you being an external advisor, but what's a typical week like for you?
That's a good question. These are good questions. I have to say that my parents still don't know exactly what I'm doing. Because I don't have a schedule, a daily schedule in a hospital or in a clinic. I just have this one day each week, okay? And the rest of the week, it's assessing or from home or at the clinic with professional teams or professional players. So depending on what they demand, I do a thing or another. So I schedule video conferences with a lot of teams daily to discuss about injuries. We look at the images, the physiotherapists explain and the doctors explain me all the clinical aspects and all the things and then we discuss about how to plan the return to play time for that player. Okay.
I see.
Some others, especially when they get some re-injuries, which for me is the worst thing we can have in sports medicine, the re-injury, not the initial injury.
Right.
Because every time you get a re-injury in the same area, the tissue is of worse quality, so it's most difficult to treat and to readdress. Right. So sometimes in that cases, they bring the player here and I reserve all the morning or all the afternoon just to make every kind of test that I think we need to address exactly that player. And from there, we have a complete map, and then we can progress on the rehab protocol, or if the surgery is needed or something like this. So it depends exactly. So I cannot say how is a daily, a week in my life, because it depends on the week before, according to what teams they need. You understand? And
I see.
Only day, the Thursday, I stay from 8 o'clock in the morning until 10 p.m. In the hospital, visiting amateur athletes and doing ultrasound guided procedures and all these things, and ultrasound scans and all these things.
So you're one day for sure in the hospital all day doing
and
that.
Then depending on what the players that I visit needs, I rent some spaces in different clinics to do what I need. So if I need an MRI, I rent a space in a clinic which has the possibility to make an MRI, and then we discuss the MRI with the medical team and with the player and all these things. And if we need, for example, to apply some biological therapies, then I rent another space in another clinic when they do the biological therapies better than anyone. So I move to different clinics according to the needs of the team and players.
But this is all within Spain, I take it?
Yeah, it depends. Some of the clubs want me to go there once a month, for example, just to make our educational sessions, or to have a meeting with all the staff and discuss once a month about all the injuries they have. But it depends on the arrangement I have with the clubs.
Okay, I see. So you have arrangements. I'm looking so many leagues: Premier League, Italian Serie A, Spanish La Liga, China Superleague, you name it. What was the first club you actually started working with? Because I'm trying to piece together how you actually made this transition to mostly advising these teams and only being in a clinic once a day or once a week. I'm sorry.
No, that at that time, before I had all these teams, I was at the clinic more times a week.
Yeah.
I was in the clinic almost daily.
Right.
But as I said, the team I started with was Football Club Barcelona to collaborate with. Okay. And that was the first team. But nothing has come in my life. Nothing has come easy. Not the whole teams have come to me all together. It was first one player from a second division, then that player told another one, then they are coming to, and during the last 12 years that I've been doing sports medicine, it was one player first, another player, then as I assess 4 players in the same team, the team contact me. So if they are going to come to you, better I come to you as a club.
Yeah.
So I can control what's going on outside. So it was like this. So I started assessing some academic teams in Football Club Barcelona, but not as a team doctor, just as an assessor of what they need. And from there, some players went out from Football Club Barcelona. They went to other teams. They spoke about me to other guys, and they come one by one. And every time that was growing a little bit. And now, for example, this year that is starting, I think that I have 19 teams from all around the world. Yeah,
Wow.
it's quite good,
That's
man.
impressive. Yeah.
Yeah.
And I know this may make you feel a little uncomfortable, but what 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 about your skill set personality has really set you apart? I know that you obviously really love what you do, but what maybe had the players, what do you remember them telling like their clubs or other players?
Uh, I don't know. First of all, players, if the player want to comes to you, it's much more easy.
Mhm.
It's much easier, okay? Because they come very open, okay? If the club makes the player come to you, it's much more difficult.
Pretty much you were saying that, obviously if the players had a good experience, they're going to come. Because I was just curious, what did the players see in you to want to share, hey, I had such a great experience with Dr. Pedret. You should check him out. What do you think? I know it's a hard question.
I don't know. I really don't know. It's a good question. I don't know. Maybe I solve their problems. I really don't know. The thing is that I don't sell anything. So they come, I assess them. I don't try to sell anything to them. So I just give my opinion, my real opinion,
Yeah.
what I really think, because sometimes what they really need is to know exactly what's going on with them.
Yeah.
We need to put in the mind of a professional player that he has a good career, and from the last month he's not able to recover from an injury, because a player just come to you, just want to come to you when he struggles with his rehab. Okay, so if he stays in the club and the problem is solved in a few weeks, he won't come to me. Okay,
Yeah.
but if he starts looking at his problem, the club doesn't have maybe the solution, he sees that he's not able to perform as he was doing before, then he starts asking and looking for a solution,
Yeah.
and then they find me, and normally if we stay in his mind, what he really wants is to understand what's happening.
Yeah.
And normally what I try to do always is to explain the player what's happening and why he doesn't recover or she doesn't recover so well of the injury, or why he or she has continuous re-injuries in that area.
Yeah.
And I think that they are grateful for that, because they just need a guy that make him understand what's going on, not trying to sell anything, not trying to, okay, we're going to do a lot of things, a lot of money, no, I just try to explain what's going on, then we will try to find a solution according always with the club.
Yeah.
So I think it's ugly to go from behind the club.
Yeah.
I would never do that, because it's problematic for the player also.
So I'm assuming, and I don't know how these contracts works, but if a player comes to you and they are a part of a professional club, do you need to just let them know, hey, we need to circle back with your medical team? I can't really just discuss this with you, even if they say they've gone on vacation and they decide to just stop in to your clinic?
It depends.
Okay.
Sometimes they are on holidays, and they come to my clinic to have a second opinion of some problems from
Okay.
behind of the club. And if it's just a second opinion, I can tell them. And if they say, don't speak with my club because I just want to know what's going on here, and it's just one visit, we don't need to make anything specific outside the club, then I just make the visit and nothing else. But if we need to make a follow-up, or we need to make some kind of treatments that are not just physiotherapy treatment or rehabilitation protocols, then I tell the player that we really need to speak with the club without any problem. That won't be a problem. If you speak sincerely with players and clubs, you don't have problems.
Yeah.
Okay. So this is my main basis, because if the player goes behind the club, we start doubling workloads, we start doing things that maybe are different from what they do in the club, and this is bad for the player.
Yeah.
So we need to work together, and that's the reason of why now the clubs is the ones are coming to me more than players themselves.
Yeah. And going back to the clubs, you made a comment, and you kind of stopped for a second. You were saying that it's easier for players to come, but it's harder for clubs. Can you explain why?
Yeah. The clubs have their medical staff. Normally they have a doctor. Normally they have a lot of physios. If this is a good a high level club, has a lot of physios, has a lot of physical trainers, and all of them is the medical staff of the club. So going outside some years ago and demand another opinion from outside the club was seen as a weakness. But it's not. It's not. Absolutely not. So this is the problem a few years ago with clubs. Nowadays, this is not a problem, at last in my experience. The thing is that if the player wants to come and the club doesn't, this is more problematic. And the same if the club wants the player to come to me and the player doesn't want it because he has his own doctor in another country. So we need to work together. If we are not in the same line, the things are not going to progress. And this is a thing that clubs, players, and me and everyone should understand.
Yeah, I see.
Okay. And players know that sometimes in clubs there are political issues about managing some injuries. And every time more players have his own medical team, small micro medical team. They have a doctor of reference, they have their own physiotherapist, and they have their own physical trainer, and they have their own micro environment outside the club to assess him in all these things. And here we can find people that are confronting the club and people that wants to go in the same line as the club. And I think that we need to go on that side, because if not, it's bad for the player for sure.
Yeah. Now, obviously there are politics in any sport, in any business, but as an external advisor, you're essentially coming in as like a neutral person to make or confirm a diagnosis or determine a return to play. And I imagine, of course, you know what you were doing, but initially, were there any challenges like stepping into this kind of role, aside from obviously making sure that the club and the players are on the same page?
Yeah. In the beginning, it was really challenging, because now I have a database of all injuries I treat in professional players, and divided from a sport, from position, and now I can really make a return to play prognosis very, very accurate, because I have a lot of database of that kind of the same injury. But in the beginning, it was a little bit stressing to make an accurate prognosis of an injury, because it was a little bit blind. So we have an injury, I describe the injury, and when clubs or players say, okay, when I will be able to play again. This was difficult, because normally in the beginning, players only came to me when, as I said, when they have lots of re-injuries in the same area. So they were desperate finding a solution. and making an accurate prognosis of multiple re-injured site is very, very difficult. So it was challenging. Yeah, it was really, really challenging at the beginning.
So how many, I guess, I imagine it took quite some years for you to get this data, because these are data from players, not just reading an article, right?
So, yeah.
Yeah. Wow.
Yeah. It's my own database. So it's just a table that I use the same criteria of the UEFA studies, which I think is very, very good to report injuries. And every injury I assess, I try to fulfill the complete issues of that injury according to that database and to UEFA studies. So in the last 10 years, as you can imagine, I had a lot of injuries. So the database now is quite big.
Yeah.
So if I have an injury affecting the common tendon of the hamstring in the proximal third without retraction and classified as a BAMIC 3C injury, for example, I can find in my database football player in the same position with the same injury, which is the mean return to play they have. And I have probably in that kind of injury, I have 30, 40 injuries at the same time in that kind of players, in that kind of a sport, in a midfielder. Wow. So it's quite accurate, the return to play time.
Would you recommend just early clinicians doing that with the injuries they get, just to build their comfort? I mean, obviously there are certainly research articles, there's some, muscle grading that determine, the approximate time, but for new clinicians, is that something you would highly encourage?
Yeah.
Okay.
Yeah, absolutely. Absolutely. There are very, very good articles and very good research about that. And I really encourage the newcomers to that to read that papers, because they will have at last they will have a time frame quite approximate to make his own opinion.
And what paper was that again?
There are a lot.
Yeah, I was going to say
I have to say that there is I don't know how to say that without being politically incorrect, but scientific literature and medicine literature, especially in sports medicine, it's a little bit controversial.
Yeah.
To say it soft. There are very good articles, but there are very, very bad articles that are published in very famous journals. So we need to be critical when we read, and we need to understand which is a good article and which one is not, although it is published. So publishing something doesn't make it real. Okay, and practical. So for example, the group of Noel Pollock and all the classification of the BAMIC, applying the BAMIC classification are very good articles to know the approximate return to play time for every kind of muscle injury. Okay, that's a very good articles. But as they say, these are articles normally for track and field sports and for hamstrings. The thing is that as the classification is quite easy to use, everyone starts to apply the classification to everywhere and to every sport. But the classification is done in track and field and for hamstrings. So yeah, it's very good to read that kind of articles. Also, the epidemiological studies of the UEFA team, Marcus Walden, Martin Haglow, Jan Ekström, all of these geniuses, which are publishing epidemiological studies for more than 10, 12, 15 years ago. And they send the basis of how to make your own database. I think that these articles are also very, very useful. And there are other articles of other classifications. The one from Xavi Valle in the Sports Medicine Journal, which is another kind of classification, complicated to use, but very precise in the terms of defining every kind of injury. So this is another very interesting article. So there are very, very good research that newcomers or for physiotherapists, physical trainers, doctors that start in this world, they need and they must read to understand what's going on here right now.
And you brought up on a good point regarding to not every article is a good article. Obviously, everyone's working hard to publish information to contribute to the sports medicine world. But I guess take me through your mind when you are trying to critically appraise an article to determine whether it's good or not. Obviously, we know systematic reviews, randomized controlled trials, those are typically the higher level evidence. But what helps you determine if this is an article that's actually a good one for the given population that you're working with?
Yeah, this is another good question. The thing is that we need to be aware with the clickbait and with the yellow press articles. That's my opinion. So some journals took the tendency of the easy clickbait and the shouting titles. Of articles. I remember one that makes me bleeding my ears, which was Bye Bye MRI. I always remember that title article because it's crazy.
Clickbait for sure.
We can't live in sports medicine without MRI.
Yeah,
that's for sure nowadays, because we need to see the injury, and nothing is as accurate as an MRI nowadays. Mm-hmm. So an article saying bye bye MRI, it's just publishing for publishing, in my opinion.
I see. Yeah.
Okay. So this is one thing. Another one, when I make reviews for journals, what I normally look is the methodology. So you cannot compare treatment if you don't apply it in a case control, for example. So say that a treatment is very useful, just testing 3 rats, that's not a good article.
Right.
And there are papers published that is saying this treatment could be really useful in the daily practice, and you look the methodology and they test the treatment in 3 rats.
Not enough.
So, and we need to go a little bit deeper again in what we read, and not just read the conclusions or the abstract. We need to understand why they are saying that. Mm-hmm. And we need to think, okay, that's a good treatment or not. Let's see how they do. And they treat just 3 laboratory rats with that treatment. That's not a good treatment, as far as we know, because we don't know if it is it or not. Yeah. You understand? So that kind of things. I normally use the methodology to understand if there is a good article or not.
And that's a good point that you mentioned, because I'm not guilty of it all the time, but sometimes if I'm in a real rush, I try to get through the conclusion abstract, but then it's like, make sure, the population, the age, it kind of matches up with the people that you're actually treating to really make a accurate, conclusion based if it's going to help you in your practice. But talking about MRI, with that clickbait title, like you mentioned, what we have today is the MRI, which is really the most effective tool to determine kind of the prognosis. Is it within the first 48 to 72 hours?
Yeah, or even before.
Even before that.
Yeah.
Now, at a professional level, these teams probably have no issue getting that MRI. But when we're looking at lower levels, such as a youth who may not have access that readily, how tough is it to determine their prognosis if you don't have that MRI within that time frame?
No, the thing is, if you have the possibilities, if you are a high level team, and you can do it during the first 72 hours, I always say the same. Just spend the first 48 hours to have an accurate diagnosis. Don't do anything more than try to find the diagnosis. So the high level teams don't have any kind of problems in that because they can perform the MRI at 24, 48 or 72 hours. Okay, the problem we have with the teams that don't have that, or the amateur athletes.
Yeah.
Okay, then if you have access to MRI, but you cannot have access in that period, in that time frame, you can do it at 1 week or at 10 days, but we need that MRI. Okay. Because the alternative, if you don't have the MRI, it's the ultrasound. Okay. And the ultrasound is much easier to reach. It's not invasive. It's cheaper. It's very easy to use if you know how to perform ultrasound. And you can do that. The thing is that you can know with ultrasound that something is going on there, but you never reach the detail of the injury that can reach the MRI. Yeah. So, for example, if you have, again, an injury, a longitudinal split injury affecting the common tendon of the hamstrings in the proximal region, okay? If you go with ultrasound and you make the ultrasound scan, you will see for sure that something is going on in that common tendon, okay? That you can say that probably there is a rupture, but most of these longitudinal splits, you won't see them in the ultrasound scan. It's very, very difficult to see a longitudinal split. With the MRI, it's very easy. But you can say to the amateur player, you can say, okay, something is going on in that common tendon. Probably it's a small rupture. So we will need to treat it as a small rupture in that common tendon if you do not have access. And with the ultrasound and the clinical exploration and clinical test, you can have a quite accurate idea about the injury. Not as accurate as if we have the MRI, but we can go on with that kind of diagnosis also. Okay. So that with amateur athletes, I don't prescribe MRI. So clinical exploration and ultrasound scan, and we go on from there.
Okay. Now, going to talk about rectus femoris injuries, you presented at the Isokinetic Football Medicine Conference in Lyon for those of you who weren't there. So with rectus femoris injuries, we know this is a two-joint muscle, very powerful, commonly gets injured in soccer players. And like you mentioned, the healing time frame can really differ depending on where this injury takes place. Just from your personal experience, what's your least favorite rectus femoris injury to deal with and why?
For me are the central tendon injuries.
Are those the worst prognosis ones?
Yeah, especially in football players. I have to say that I have two debilities, which are calf muscles and rectus femoris. So I really love that muscle because they are very, very complex. And rectus femoris is a muscle that has huge complexity, starting from its anatomy. Yeah. So the fact that it has a very powerful tendon inside the muscle that acts as a whip when you kick the ball or when you're sprinting, it makes it very, very, very special muscle. So that whip we have inside recruits muscle fibers when you start to prepare the kicking shot in football. So it has a terrible strength in that area, and it's submitted to lots of tension. Yeah. So when you have a rupture in that central tendon, the clinical aspects is very hard at the beginning, but then it decreases quite fast, so the player doesn't feel almost anything. And then everyone make the mistake to push the player a little bit more than normal. Or we push more than the level it should be.
Yeah.
So we create in that structure a soft scar, a chronic soft scar tissue that makes continuous ruptures, and the player never feels good. So for me, the most scaring injury in a football player, or one of the most affecting the rectus femoris, is the affection, the complete rupture of the central tendon, a transversal gap of that central tendon. And if we have retraction, worse, even worse. Okay, because we need to be very, 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 very good in the treatment, not to progress as a chronic soft scar in that area.
Yeah. And this central tendon injury, can this be seen on an ultrasound or an MRI?
Yes.
Definitely.
Yes.
Oh, that can, because it's deeper, right?
Yeah, it can be seen perfectly in ultrasound, the central tendon. Mm-hmm. But the thing is that if we follow the central tendon to proximal, then we start with the problems with the ultrasound. So the complex anatomy of the direct tendon that is coming from the anterior inferior iliac spine, and the reflected tendon that is coming from the hip joint, inside the hip joint and the capsule, has directions that ultrasound cannot understand, because one is coming straight from the anterior inferior iliac spine, but the reflected tendon, it's coming and makes a complete curve to join to the direct tendon and conform the conjoined tendon. So that area is where ultrasound loses the most of his ability to diagnose. So in the most proximal part to assess tendon injuries, we need an MRI. This is one of the bigger mistakes that we can do, try to assess the proximal part of the rectus femoris just with ultrasound. And then in the middle third and the distal third of this central tendon, with ultrasound, we have enough to see exactly what's going on there.
Okay. Have you had instances where you had the central tendon injury and it didn't seem to recover and it required surgery, or is this normally something that typically with the targeted exercise, individualized program for them, it will heal?
If we speak about tendon injuries, direct tendon and indirect tendon or reflected tendon injuries, I always suggest to have the opinion of a surgical, of surgery, because especially if in the MRI we can see loss of tension of the direct or the indirect tendon, then I always recommend to have a surgical advice.
Yeah.
Okay. Because they go really, really well with surgery. Okay. The other kind of injuries, the ones affecting the central part of the central tendon, the middle third, which are the most frequent ones, I normally use just rehabilitation and physiotherapy treatment. And if we do it correct, we can go perfectly without any kind of surgery. And we don't need to think also in biological therapies. So with physiotherapy and a good rehabilitation protocol, we can progress quite good. But we need to be very, very, very accurate to treat that, because if not, we will enter in that chronic soft scar stage.
Okay. So there's a central tendon injuries, but then what about just myofascial injuries that tend to seem to have a return to play around 3 weeks, give or take? Would you say this type of injury is typically one of the best prognosis when it comes to a rectus femoris injury?
Yeah. Myofascial injuries, which are located deep posterior and lateral, normally, this is the main location of the myofascial injury, are very good in terms of prognosis. So 3 weeks, it's more than enough. But I treated myofascial injuries that the player was feeling good. The match was important, and we decided to go on. And in 1 week, he was playing without any problem with the myofascial injury. So 3 weeks is more than enough for that kind of injuries, but it could be even less. And also another kind of injuries, which are the ones affecting the superficial and anterior aponeurosis, which is the direct expansion of the direct tendon, are also of very, very good prognosis because they are very, very small normally. And sometimes the athlete doesn't complain about it because the clinical is very, very mild. So those one are, for me, the ones of better prognosis in the rectus femoris injuries.
So if there's a large amount of the aponeurosis affected, then that definitely will yield a longer recovery. And can you explain why?
It's a matter of thickness.
Yeah.
So
okay.
We know that there is a tendon, aponeurosis, and fascia, and this is all a continuum. Okay, so if you go to the cadaveric room and you say to the anatomist, okay, can you show me where the tendon ends and starts the aponeurosis, and when the aponeurosis ends and starts the fascia? The anatomist come there with a pencil and he draws exactly where the aponeurosis starts, where the aponeurosis ends and starts the fascia. But if you get a sample of that three kind of tissues and you give them to an histologist, which I did so, the histologist says to you that it's the same kind of tissue. The difference is the collagen structure and density. You understand? So
yeah,
it's a matter of thickness and structure of collagen.
Gotcha.
Okay. So as the thicker is the structure, the worse is the prognosis.
Yeah. Okay.
That's the main reason. So if you look at the literature again, you will find a very controversial articles trying to explain what is an aponeurosis, what is a fascia, what is a tendon. So the main simple explanation is that it's all the same. It's a collagen structure, but the tendon has the more structured an organization of collagen and is the more thickest structure. Then it comes the aponeurosis, a little less thick with a little less organized collagen. And then it comes the fascia, which is a very loose connective tissue with a very less organized collagen. And
Gotcha.
and that's the point. This is very easy to understand. Maybe it's not the most academic explanation. We can go a lot deeper on that. But to understand why we think that tendon injuries are the worst one, aponeurosis injuries are the second worst one, and then intramuscular and myofascial injuries are very mild, the explanation could be done like this. And it's very simple to understand.
Yeah. Okay. Aponeurosis impacted, that can play a role in the prognosis, but then also you have whether a hematoma is present or there's a proximal retraction. Are those the main ones or main factors that you kind of look at when you're really trying to determine a prognosis? Or are there other impacts or areas of the muscle that could be impacted that will help determine?
This is another interesting question. Bleeding and hematoma, it's just a sign. So it's not important for the prognosis, in my opinion, normally, okay? Because the injuries that bleed the most are, for example, myofascial and muscular injuries. And these are the ones with the better prognosis, okay? Normally, myotendinous or tendon injuries doesn't bleed. Or very, very mild bleeding, okay? And another thing is what to do if you have an hematoma inside the muscle injury. This is different because if you have an hematoma, for example, in the medial gastrocnemius, between the medial gastrocnemius and the soleus muscle, you need to drain that hematoma. Because if not, you're going to create a scar tissue of that big between two muscles that needs to make a shearing movement continuously. You understand? So if you create a stiff and fibrotic scar injury of that big between these two muscles, you for sure will have problems in the future when you're trying to perform. Okay, gotcha. So what I look when I try to reach an accurate prognosis, especially, is the quantity and the quantity of the affection of the connective tissue, of the dense connective tissue. So if we are speaking about the rectus femoris, is there affection of the posterior aponeurosis or not?
Mm-hmm.
If there an affection of the central tendon or not? And if there affection of the direct and reflected tendon or not? These are the main points. So if the injury affects the central tendon, is there a complete transversal gap of that central tendon or not? Or it's just a myotendinous injury. So the central tendon is completely correct and the rupture is affecting the fibers attached to that central tendon. So this is, again, another better prognosis injury.
Mm-hmm.
So if as much connective tissue is affected, the worse is the prognosis.
Yeah. Okay.
So this is what I'm looking at.
Okay. So when we're talking about return to play, I noticed that you mentioned this in some other presentation, how you don't get so bogged down about an injury, but it's the re-injuries that bring more of a concern. When did you realize that in your career that you really can't stress so much about trying to prevent every single injury within a club? Because like you mentioned, injuries happen all the time, probably every practice, every training.
Yes. And this is a thing that I realized in recent years after looking lots of people trying to push too much players with injuries. So I really prefer to stay 1 more week or 4 more days in an initial injury to have a correct healing, rather than trying to push and making it a high risk of re-injury. So for me, you know that if you are in a professional football team, you will have an average of 15 muscle injuries per club and per season. So don't try to prevent that, because you're wasting your time. You will have an average of that.
Yeah.
So if you have less, that doesn't mean that you are a better doctor. It means that you're rolling dice, and that season it's a good season. Okay. Yeah. The best method to prevent injuries for me is assessing as much individual risk factors as you can in your players. Mm-hmm. This for me is my opinion. So if they have a weakness in the core stability, work that. If they have some kind of asymmetry in lower legs, manage that. All these things are the best things you can do. Yeah. Apart from that, you know that you will have between 12 and 17 in normal numbers of injuries. So the most important thing is not trying to decrease the return to play time a lot. The most important thing for me are that these injuries don't have a re-injury. Yeah. So that's why when some people say, I try always to push, and if we pushing and we don't make imaging test and we just push the player to recover, the return to play time is less than if you take into account a lot of things. Yeah, but they don't say that the re-injury risk is also much more higher than if we take into account all of the things that we really need to consider when planning the return to play. So I don't want to be the faster one recovering injuries. I want to be the safer one. Yeah. You understand? So that for me is the main goal, the re-injuries, to avoid that.
And you talked about how with players, obviously the tailorized program for them to get them to return to play is important. But there are other factors that can decrease a muscle capacity, whether that's fibrosis, the immature scar, the injury size. Are there other things within a player's control that they can try to help limit that? Are there things that they can and can't do to maybe help limit that?
Yeah. I think, and this is maybe an unpopular opinion, but I think that we are the responsibles of not having a good treatment. Sometimes we want to overact in an injury.
Like do too much?
We want to do too much things because the player can see that we are doing a lot of things to take care of him, because we don't know how to stay just waiting and see the evolution. But the tendency is to overact with an injury. Injuries and biological tissue has his biological times in terms of recovery. So we won't change that for sure.
Right.
At least now. I don't know in 20 years if we could make some genetical treatments to assess that. But in this moment, we cannot do anything to make a faster recovery of the biological times of every tissue. So what we just need to do is to guide that time to recover, not to reach a fibrosis. And we know that we can do that with some exercises, not complicated exercises, isometric, concentric exercises, normal ones, and then progressing to eccentric, different loads of eccentric. So we can apply that from very soon to avoid a fibrosis of that injury. But we need to understand that if we stress so much the injury side, we are not leaving that side side to recover correct, because we are sharing the injury side continuously. So I think that we need to be conscious that we don't have to overact in an injury. So we need a very accurate diagnosis from the beginning, and we need a plan. So
are you telling me that oftentimes some of these players, they won't, like, if they have the appropriate plan, diagnosis, all of that, they might not develop fibrosis? Because I imagine that there are still players that have these injuries, the extent is a whole lot, they still develop fibrosis. What do you say in that case?
Fibrosis is a less bad solution. So it's not a disaster.
Right.
For me, a disaster, it's a chronified soft scar, which is a region of the injury that isn't able to support any kind of load because it has no tissue in there, no concrete tissue, because we overstress that area during the process, and it suffered a lot of re-injuries. So the tissue there is completely weak and without any kind of sense and structure. So this, for me, is the most critical thing. So we can deal with the fibrosis because we have tools to readapt the fibrosis. And we can see, if we have MRI scans of 100 football players, we will see a lot of fibrosis in that muscles without any kind of symptomatology. So fibrosis is a state that in more or in less degree we are going to reach after an injury. Okay. So we need to make that fibrosis the less big and the smaller and thinner as possible. This is our goal, but we will reach some kind of fibrosis. So
it's really the soft scar, though, that can pretty much jeopardize an athlete's career if they don't build that. I see what you mean. Okay.
Exactly.
Well, finally, I know this is a soccer medicine podcast, but I do have to ask, because I asked you to send me some photos and you sent me some great photos, but you sent me one of Kobe Bryant. And I grew up playing many sports and I was a fan of just all sports. I didn't like playing organized basketball, but I loved playing pickup. And Kobe Bryant was the one athlete who I hoped that I'd one day meet. And I just felt like I always drew inspiration from him, listening to him early in the morning when I'm getting ready to train. I guess, how and where did your paths cross?
Because of his problems with the Achilles. He came to visit me 2 or 3 times.
In Spain.
Yeah, he loved Spain.
He's a football fan too.
Yeah.
Yeah.
He's a Football Club Barcelona fan. He was, yeah.
Yeah. What sticks out to you about his personality? Just the time that you had with
I
him.
have to say that I'm not a mythoman, so I don't really normally take photos with great athletes, except selected ones.
Yeah.
And for me, he was a selected one. The way he saw everything, the way he saw the basketball world, the sports world, don't know.
Yeah.
It's an immediate connection with the way of thinking, although he doesn't speak so much. We just see each other 3 times, and one was a little bit more extensive because we had a coffee and all these things, and we could talk a little bit more. But it's the thing that it's the Mamba mentality,
Yeah.
you know.
I know. Yeah.
So
Yeah.
I cannot explain that.
Yeah. I know I've never met him, but definitely I still feel like some of his, just the Mamba mentality and just his drive still pushes me today when I feel like I'm so tired. Well, finally, for future sports medicine doctors, I know they always like to hear the opinions of those that have been there, done that. When you look back at your career, what do you wish you heard earlier?
That it's difficult to say that because the way I arrived here, as I told, it's very strange.
Yeah.
So maybe the thing that I wish to hear that before is someone that told me how we can manage injuries without making them worse. Because as I said, the tendency of every young people, especially physiotherapists, is to act so much and apply a lot of techniques and strange things to be better. And no, you just need to have the knowledge and calm down. So I would,
I like that word, calm down.
Because you have a professional player. You are young, probably it's the first professional player you reach to, and you are more anxious than the player. And you need to have the knowledge and calm down and not to overact and just follow the biological process, and the injury will get better for sure. So I think that this could be a very good advice, because the tendency goes absolutely in the opposite direction of this what I'm saying.
Yeah. Well, that's some good advice. Well, what's next for you? What are you working on? Any projects coming up? Any research? Right now?
Always. I'm working on projects and things, but the most interesting one is trying to build even more the injury database.
Oh, okay. And is this just for you, or will it be for people available to?
No. I try to involve some team doctors to put all the injuries they had during the season, even also the ones that they not comment to me, so the ones I don't assess. So in order to have a huge muscle injury database in football and in different sports, because I also reach basketball and tennis, in order to have for every practitioner a real injury database, so they can consult and say, okay, I have this injury, this exact injury, let's see the mean average return to play time, but according to injuries in the same sport, in the same kind of players, in the same positions, so they can have a really good map of where they are exactly. So this is what I am trying to do now, and also I am writing, but this is in Spanish, a divulgative book for sports, for amateur sports guys, to understand a little bit what's going on with their body, without having the opportunity to reach all the tests and all that, and they don't understand why they have injuries and all these things. So it's a divulgative book for amateur sports players.
Wow, very impressive. Well, I know us in the States, I can speak for myself, definitely are appreciative of so many people like you that have contributed so much in the sports medicine world. And if I'm ever in Spain, I'm going to have to find you, okay? I know I'm going to visit there someday, okay?
Okay, you should.
Now, thanks for tuning in. Be sure to rate, subscribe, like, tell all your friends and colleagues because more good content is coming your way.